Interspersing very short high intensity interval during moderate intensity aerobic exercise may be useful to lessen the decline in blood glucose during the early post exercise recovery period. A greater emphasis should eventually be placed on vigorous intensity aerobic exercise if cardiorespiratory fitness is a primary goal of the exercise program and not contraindicated by complications. Better overall blood glucose control may be achieved by engaging in vigorous intensity exercise training. Both high intensity interval training and continuous training are recommended forms of vigorous intensity exercise for individuals with diabetes mellitus. For type 2 diabetes, allow no more than 2 consecutive days without aerobic exercise to prevent a period of excessive decline of insulin action. So, for exercise prescription, this is FITT principle of exercise program for healthy adults generally applies to individuals with diabetes. Participating in an exercise program confers benefit that are extremely important to individuals with type 1 diabetes and type 2 diabetes. Maximizing the cardiovascular benefit resulting from exercise is a key outcome for both types of diabetes. So FIT protocol is exercise should be done according to FIT principle. FIT, F stands for frequency. Exercising, it depends actually. If you want to maintain your fitness, you have to do it 3 to 5 days. Or if you want to reduce weight, then you have to do it probably every day. Maybe 1 day rest. So intensity is our 30 to 40 minutes of exercise at 50 to 60% or 50 to, depending on your fitness. You can go up to 80% of the target heart rate. Type is again the safe exercise is they are preferable. Time is again how much time you want to devote it. This is an example of walking program. So week 1, important thing is that whenever you start aerobic exercise, you have to tell your patient he has to do warm up, then do exercise, and then cool down time should be there. Otherwise he will injure himself and muscular problems may be there. So this is session A. Walk normally for 5 minutes, then walk briskly for 5 minutes, then walk normally 5 minutes. So total duration will be 15 minutes. Warm up and cool down time will remain the same. And gradually you can, by week, you can increase depending on your fitness, briskly 7 minutes, 2 minutes interval, or you can increase even more depending on the person. Week 13 and thereafter check your pulse periodically to see if you are exercising within your target zone. As you get more in shape, try exercising within the upper range of your target zone. Gradually increase your brisk walking time to 30 to 60 minutes, 3 or 4 times a week. So benefit of aerobic exercise, building stronger bones, improving your muscle strength, endurance and flexibility, improving your balance, increasing your mental function, and believe me, it definitely improves stress level, assisting in weight management and or weight loss. In addition, aerobic exercise can reduce your risk of developing heart disease, hypertension, stroke or diabetes, improve your lung function, lower your blood pressure, increase HDL or good cholesterol, help to better manage your blood sugar. I already told about a warm-up period, a progression of the exercise and cool down period. These are the 3 components of exercise which you should prescribe. Warming up and cooling down, every session of aerobic exercise should include a warm-up and cool down period. The warm-up period should not include static stretching but should instead be a gradual increase in the pace and intensity of the exercise. This allows your body to increase blood flow to your muscle and decrease the likelihood of muscle or joint injury. The warm-up should last between 5 to 10 minutes. The cool-down session should last a similar amount of time as the warm-up, with the pace gradually decreasing. Stretching exercise should be appropriate after aerobic exercise. Progression of aerobic exercise, progression or movement of higher intensity or how much work your body does during exercise should vary during your activity. The progression of the activity based on your tolerance and strength. If you are just starting, you should take it easy. If you are training for a marathon, you can steadily increase the level of work your body does during your workout. There are 3 ways to progress an aerobic exercise: increase speed, increase resistance, and increase duration. So with that, I will end my session on aerobic exercise. Thank you very much. If there are any questions, I will be happy to take.
Sir, we will discuss the questions at the end.
Yeah, sure.
So I think you are now clear that the aerobic exercise is the very, very important intervention for to include in the exercise prescription.
Resistance in aerobic exercise.
Which one?
He has written increase resistance in aerobic exercise.
That is, suppose you are working on treadmill,
Uh-huh.
so you can increase the resistance.
Acha, but I thought that was used for anaerobic. So in aerobic also increase
No,
the
no.
time, increase the
Intensity and resistance, both.
that. Acha.
So actually in my patients I tell that the walking, fast walking is the simplest and the best mode of aerobic exercise. But many people will tell you that we have got the osteoarthritis, many cardiac problems, some problems. In that cases, the component of exercise like resistance part, a stretching part, aerobic part, and some now new concept and new, I think, hope is the HIIT, that is the high intensity interval training. So many things are combined in the yoga. So I kept next 5 to 10 minutes for the yoga, and I request Dr. Amal Bhattacharya. He has come from the Baroda. So next you are. After that session, that Akash, after session.
I will also like to comment on that.
Yeah,
but
after that we will just for 5 to 6 minutes, please point up.
Thank you, Dr. Vijay Patni, to give the chance, and Dr. N.K. Singh to start ruling the matter. Topic is yoga and diabetes. Yoga, which is origin from the our country 5,000 years ago, aims at balancing and harmonizing the body, mind and emotions. So there is a difference between exercise and yoga. Exercise is only physical characteristic, but yoga includes mind and emotion. Increasing evidence suggests that yoga practices tackles the pathophysiological mechanisms of diabetes and helps in controlling diabetes and its complication. There are more than 100 neurotransmitters secreting from the brain, and it takes care of all of which can soothe, or they are inhibitory in nature. One of them is GABA. In this short review, we briefly describe the role of various yoga practices in the management of diabetes based on evidences from various clinical trials. Recommended practice based on evidence of diabetes. Yoga practice is a complex intervention with various components include cleansing process, that is known as Kriya, posture, which is known as asana. It is the third component what Patanjali described. Control breathing, pranayam, meditation, relaxation, chanting mantras, yogic diet, code of conduct, philosophy and spirituality. These are interwoven and interdependent. Many yoga practices have been found to be beneficial in the management of type 2 diabetes. However, their judicious use is recommended after a careful assessment of a patient's overall health, individual requirements, so we have to customize depending on the patient's type, associated risk factors and contraindication. By considering the person as a whole, including physical inactivity and poor health behavior, yoga practices of high or low intensity may be prescribed. Some yoga practice is beneficial for the management of type 2 diabetes. Yoga technique one side, and there we will see how much patient has to endure. Cleansing practice, that is Suddhi Kriya, Kapalbhati frontal blend purification, 5 rounds, 120 strokes each. Agnisar Kriya, stimulating the digestive fire, 5 rounds. Vaman Dhauti, stomach cleansing, once a week. Full Sankh intestinal cleansing, Sankha Prakshalana, once a year. It is for a long time and whole intestine is clean. If you want some part of it, that is Lagu, then probably it is cleansing of the stomach and duodenum only every 40 days. Preparatory practice, warming up 5 to 10 minutes. Surya Namaskar of various number, slow speed 3 to 7 rounds according to an individual capacity. Now the yoga posture asana is also important, how you practice this perfectly. Suppose on the right side there is a picture. Both hands are at a straight line. So is the leg. Looking at the top by the person, and neck is also straight. So this posture has to be maintained in perfection to get the benefit. This is a standing posture. Trilokasana, triangle posture. Tadasana, palm tree posture. Triyak Tadasana, that is a bent palm tree posture. And a Virasana, that is a warrior posture. This is a seated posture. She has extended left leg, flex the right, turning to the right, both hands at the same angle, and they are also straight, looking on the right side with spine, neck and head straight line. Vakrasana, spinal twist. Ardha Matsyandrasana, Mundakasana, Ustrasana, Paschimottanasana and Yoga Mudra. Because of brevity of time I could not get picture of all. Prone position, it is known as a Bhujangasana. Bhujang means a snake. Again the legs are stretched in a straight line. Bend from the abdomen straight and try to keep the neck and head in the same position. The arm till the elbow is a straight line and that is then bended at the elbow and palm is touching the ground again snugly fit. Bhujangasana, cobra posture. Dhanurasana, bow posture. Naukasana, boat posture. And Makarasana, crocodile posture. Prone position. Pavana Muktasana, wind releasing pose. Supta Vajrasana, supine thunderbolt pose. Setu Bandhasana, bridge pose. Matsyasana, fish pose. And Savasana, corpus pose that actually put patient at a rest, including mind and emotion. That can be done before sleeping. Now inversions. When there is a shoulder stand, Sarvangas, Halasana, plow pose, regulated breathing practice that we can do with little bit training, that is pranayam. Anulom Vilom, alternate nostril breathing. Chandra, Vedan, left nostril breathing. Surya, right nostril breathing. Bhastrika, below's breath that also actually contract the abdominal muscle, which reduces the abdominal obesity. Waist hip ratio. Brahmari, humming breath, it actually increases your strength of the lungs, so it also increases your vital capacity. Sitali or Sitkari. So mechanism of benefits of evidence from the clinical trial, there are a lot of done. Yoga is based on the principle that the mind and body are intimately related. It improves flexibility, muscle strength, circulation of blood, and oxygen intake by the tissue. Yoga exhibits many health benefits such as improving physical fitness, relaxation and awareness of self. Various lifestyle disorders, including diabetes, can be effectively addressed by the practice of yoga. Given acceptability, high levels of adherence, it need to be done daily. If it is done intermittently, the probable benefit may not be there. Yoga practices improves an individual's discipline regarding food and exercise, thereby helping to modify patient-related reluctance that result in the underutilization of exercise as a treatment modality. Yoga asana also modulate gene expression and increases muscle activity, strength, endurance, flexibility and balance, result in favorable effect on body weight, adiposity, dyslipidemia and insulin resistance. Yoga also prevents the development of diabetes in high-risk individual, that you can say pre-diabetes. It was found to improve symptom scores in people with diabetes. It also results in reduction of fasting blood sugar, postprandial, HbA1c, anti-diabetic drug requirement also reduced and suggesting improved glycemic control. Yoga results in a reduction in body weight, body mass index, weight to hip ratio, body fat percentage, body fat mass, skin fold thickness, and thereby increase the lean body weight. Now this is the important slide to say there is a mechanism of benefit of yoga practice in type 2, blood pressure, hypothalamic pituitary adrenal axis and growth hormone. So by behavioral change, it increases by physical activity and adherence to diet and medication. This change can be achieved.
Dr. Amil bhai.
Last slide.
Yeah, thank you.
Psychological changes and physiological changes. To conclude, yoga therapy is relevant for wellness as well as for illness so it can be done for a fit person also. Yoga practices such as cleansing processes as the various described helps to minimize the glycemic variability, and that helps to control blood sugar in various mechanisms. Thank you.
Thank you, sir. I think now he has given a brief view of what the yoga does in diabetes. We have got now lots of research works are being done, and already there we have got many prospective and retrospective studies, and they are establishing slowly the impact of yoga on diabetics. So what I conclude, sir, कि if patient is not disabled, the Surya Namaskara contains everything: aerobics, resistance, even the stretching, everything, even the meditation with the mantras. So breathing also. So I think even that is a very important. It takes only 5 to 10 minutes to do. So that is a very important point to understand. Now, the most important point in our diabetic patients, everyone is saying walking, running, but no one is telling you that the resistance exercise is the most important part at present in the diabetic practice. If you prescribe, if you generate an exercise prescription. To know that, I invite Dr. Akash Singh. He is, I think, again known to this gathering from the Baroda, to tell in 5 to 6 minutes about the resistance training in diabetes.
Thank you very much, Dr. N.K. Singh. I also wish to acknowledge Dr. Vijay Patni and his entire team for calling me here. I'll be talking about resistance training in exercise. Type 2 diabetes is a major socio-economic problem, and exercise training has received increasing recognition as a cornerstone in the prevention of and treatment of type 2 diabetes. And emerging research suggests that resistance training is the key to sort of, and has the power to combat metabolic dysfunction in patients with type 2 diabetes. Now, it is a fact that the skeletal muscle mass after 30 years of age declines at the rate of 3 to 8% per year, and this leads to rise in the risk of developing type 2 diabetes, because skeletal muscles are the organs for which are responsible for major disposal of protein, of glucose and the lipids basically, and the triglyceride metabolism is very much affected at the level of skeletal muscles. Now, recognizing its immense potential, the American College of Sports Medicine has in 1990 recognized resistance training as a contributing factor to a comprehensive fitness program for healthy adults of all ages. Resistance training should be continued lifetime to maintain its metabolic and health benefits. So you know that at the core of metabolic dysfunction, at the core of type 2 diabetes is something called as mitochondrial dysfunction and mitochondrial inflexibility. This is characterized by insulin resistance, impaired glycogen synthesis, lipid accumulation, and impaired mitochondrial function. These are the pathophysical changes at the level of skeletal muscles, and aging per se has an influence on skeletal muscle loss, but the metabolic impairment and functional losses can largely be counteracted by exercise training, especially by resistance training. And let me tell you that the benefits of resistance training are tremendous even in elderly population. It is not confined to the younger population, it is not muscle building, but the metabolic benefits and the mitochondrial function improvement are equally pertinent to the elderly population. A gain in muscle mass must therefore remain an important goal in resistance training for patients. In addition, an increase in lean mass leads to an increasing resting metabolic rate, therefore possibly triggering an upward spiral of metabolic health. Because as the lipids accumulate, as the muscle mass decreases, what is called as the sarcopenia, you will end up with mitochondrial dysfunction, you will end up with the lowered basal metabolic rate, and you will end up with lesser consumption of glucose by the skeletal muscles, you will end up with excess accumulation of fats, and all that is contributing to a decreased state of health. So resistance training enhances insulin signaling because it improves the GLUT2 receptors in the skeletal muscles. The density of GLUT2 receptors improves, and that leads to a improved insulin signaling as well as decreased insulin resistance. The lean body mass increases, abdominal fat, both visceral and the abdominal fat decreases, and the mitochondrial function and flexibility of the mitochondrial function improves. All this leads to increased insulin sensitivity, which benefit diabetes, and it can lead to a reduction of HbA1c to the tune of 0.5 to 1%, depending on the extent and type of exercise used. So why is resistance training so critical? Normal loss of muscle mass with aging, accelerated loss of muscle with physical inactivity, disease including diabetes, rapid weight loss, dieting. Because if you diet, you also lose muscle. So even if you diet, you have to go for a combined exercise protocol of aerobic exercise with the resistance training. Now, what is the impact of physical activity on fat losses? This was a study of 9 men, 16 weeks supervised exercise. Both visceral and sub-Q abdominal fat decreased by 10 to 11%, but body mass stayed same. Insulin sensitivity increased by 46%. Fasting blood glucose decreased despite 15.5% increase in energy intake. And as you can see that if you combine resistance training with aerobic, then you get the best results. You must remember that aerobic exercise is mainly for weight loss and resistance training is mainly for health maintenance, for long-term benefits on health. Combining both is the beneficial thing. Now, impact of aerobic versus resistance training. Aerobic single bout increases insulin levels by to the tune of 1 to 2 days, and that is why it is said that you do not skip aerobic exercise for say you can have a day off, but at least alternate days you should do, because otherwise the insulin levels again will fall, and there is a greater storage, glucose storage in the muscle, because as you exercise the glycogen in the muscle gets depleted, and then the other glucose in the blood and the fats are mobilized for muscle activity, but the glycogen storage also improves post-exercise also. So the glucose disposal is much more with exercise, and this is also seen with the resistance training. It has longer effect of increasing muscle mass, and therefore the basic metabolic rate also improves, health improves, and there is something called EPOC, that is the post-exercise continuous disposal of fats, which also is increased with resistance training. So the guidelines are that you should do resistance training at least twice a week, but preferably on 3 days. Just last 2 seconds.
We'll finish you in the 10:35. Don't worry.
Because of others have taken more time, I cannot skip my time. No?
You started late also.
So preferably 3 non-consecutive days you should do. 15 repetitions if you are doing moderate weights, and 10 repetitions if intense weights, 2 to 3 sets per exercise, and 8 to 10 exercises for large muscles and core. So that translates, if you exercise do 10 exercises and 3 sets, that is 30 sets of 10 to 15 each. You can use machines, bands, free weights, household items, body weight as resistance. Increase resistance when target repetitions or sets are met, then number of sets, and lastly training frequency. So you can see all of these conditions which are listed here, these cannot be subjected to aerobic exercise. They cannot do aerobic exercise, but all of these basically can do some or the other form of resistance training, and that is the beauty of resistance training. So if you don't use it, you lose it, your muscles strength train to rein your diabetes. So to conclude, there is good evidence that resistance training improves insulin sensitivity and glucose tolerance, is an effective measure to improve overall metabolic health and reduce metabolic risk factors in diabetic patients. Detailed mechanisms of adaptations that contribute to an improved metabolic profile remain elusive. It also remains to be determined whether the mechanisms by which RT improves glycemic control are the same as those that affect improvements after endurance training. Increased energy expenditure and excess post-exercise oxygen consumption in response to RT may be important systemic factor contributing to metabolic health. The beneficial effects of RT are promising. RT can be viewed as a suitable training modality to offer metabolic benefits in our time-poor society, in contrast to traditional high-volume endurance training. Positive effects of RT not only benefit diabetic patients, but can also significantly improve quality of life of elderly who are often suffering from sarcopenia and muscle weakness. So basically, you can even do it in the office, even sitting slowly a stepping and all our upcoming modalities for the same. Thank you.
Thank you, Dr. Akash. I think he has explained beautifully, at least 2 or 3 times per week, and repetitions he has already told. Lastly, अब किसी आदमी को हार्ट अटैक हो गई है, किसी को ऑस्टियोआर्थराइटिस है, किसी को किडनी की प्रॉब्लम है, रेटिनोपैथी है, इसमें क्या करना चाहिए, कौन सा एक्सरसाइज रिकमेंड करनी चाहिए? फॉर दैट आई एम इनवाइटिंग डॉक्टर रियाज अहमद. इनके पास स्लाइड्स इज टू मैनी. जैसे राजधानी चलती है तो स्टेशंस बहुत होते हैं, लेकिन मेन स्टेशन पे ही रुकती है. यू जस्ट कॉन्सेंट्रेट अप टू द CVD और आई थिंक CKD with retinopathy and osteoarthritis. That will be sufficient. Thank you.
Sure, sir. Thank you very much, sir. At the onset, I would like to thank DRW as well as Patni, sir, for giving me an opportunity to speak on this topic, because we usually don't focus much on exercise in practice, to be very honest, but we should learn. Apart from that, exercise do play an important role. I think if we can upload the slides, it would be great. So what is the main thing what we have to do is, exercise workshop. So what we have to do is, in exercise, as you know, in special conditions, the patients may have cardiovascular, renovascular, as well as micro or macrovascular complications can be there. So does exercise play an important role in diabetes to get these things addressed? Yes, that can. So in patients with cardiovascular conditions, you have to be very careful. You shouldn't overdo the exercise, you shouldn't underdo the exercise. Both the things plays hand in hand, because you know that mitochondrial as well as myocardial oxygen plays a very, very important role. In neuropathy, usually the foot sensation is not there. If the patient does not take care of the feet, then they may land up into complication and ER with septicemia as well as diabetic foot disease. Also, yeah, one slide before. So what they have to do is, they have to take care of utmost complications, which is very important. I think retinopathy also has to be addressed, because in patients, when we do exercise appropriately, then that also can be taken care. So various types of exercise, I think my previous speakers have told in detail, so that would be great. Yes, leave it, I'll take care. So as this picture depicts very clearly the macro and microvascular complications, and if you address the muscle dysfunction, cardiac dysfunction, as well as other target organ dysfunctions which are there. So what are the barriers? Especially, I think the previous speakers has told, very important, the focus will be on these 3 points. You can see very clearly, you can see very clearly the cardiovascular, if the stress is increased, the cardiovascular event rates will be increasing. Second thing is, if the nephropathy is there, anemia, definitely there is a decreased oxygen perfusion that could lead to complications. In neuropathy as well as retinopathy, which I said just 2 minutes before, when the patient has lost the pain, there will be loss of balance, and definitely that will also have an implications when they do exercise. So they have to take care of that thing also. Apart from it, vision. If I can't see, I can't be doing exercise properly. So you have to explain the patient appropriately in the brain, so that they can at least know if they have developed visual blindness also. Now, there is psychosocial aspect which is very important in our day-to-day practice, which I think we are not dealing much, and we have to address this. This is a very, very important thing. Now, polypill is very important. I think this targets with your therapy as well as with exercise. All the things can be taken care. In the matter of time, I'll try to hush this slide. The main and important thing is the physical activity and diabetes. You see, daily exercise is very much important, and at least patient 5/7, that means at least in a week, 5 days, the patient has to do exercise. That's very, very important. What are the recommended physical activities for the participation of diabetes? The patient has to be taken appropriate care in terms of the glycemic control, in terms of the muscle mass, as well as the patient has to engage in at least 150 minutes or more to the moderate to vigorous exercise. Certain conditions you have to be very careful. If they are doing moderate and strenuous exercise, that could be detrimental, and these patients may have sudden cardiac arrest also. So these things are very important. This is important for everyone. When the patient blood glucose, when the patient is suppose a diabetic and blood glucose level is less than 90, you have to be very careful. You have to ask the patient to ingest at least 15 to 30 grams of fast-acting carbohydrate. Now, if you see the patient blood glucose levels is between 90 to 150, ask the patient to take at least a small portion of carbohydrate, at least that is 0.5 to 1 grams per kg mass per hour exercise if the patient is doing. If the patient blood glucose is like 150 and 250 milligrams, you have to delay the consumption of carbohydrate because patient's blood glucose levels in the pre-exercise levels is humongous. When the patient is in ketones or diabetic ketoacidosis, you have to be very careful because these patients may land up into ketoacidosis that could be very detrimental for it. Now, mild, moderate, severe and heavy aerobic exercises, the insulin dosage and the insulin bolus dosage reduction, how has to be done is very clearly depicted in front of you. You can just have a look at it. Now, minimize the exercise related adverse event in patients with diabetes. See, when a patient is on insulin regime, these patients are notorious to develop hypo or hyperglycemia. That's called as glycemic variability, and that has to be addressed. Now that's the talk of the town to address glycemic variability. Previously, we used to talk about HbA1c, sugars increase or decrease. We never used to talk about glycemic variability. Apart from it, nocturnal hypoglycemia is very, very important because if the nocturnal hypoglycemia follows the physical activity, that reduces, that plays a very, very important role. What you have to do is the basal bolus, the patient is on basal insulin.
Riaz,
try to
conclude.
reduce
Dr.
the
Patni is becoming restless.
The type of exercises I think sir has told very clearly, so I'll be going with. This is the last slide, I'll just show it to everybody. This is in the special conditions which we have to take care. If the patient is having coronary artery disease, all daily activities are okay. Moderate and strenuous activities, you have to be very careful in patients with myocardial infarction. Because if the patient is having myocardial infarction, you have to stop the regular exercise in terms of moderate or severe. Mild exercises can be definitely taken care. That is very good. If a patient has developed stroke, you have to restart the exercise after the stroke is superseded by cardiac rehabilitation program and start a low intensity program and gradually increases because you require two things here. One is good glycemic control, muscle mass as well as mobility. All three things have to be taken care when the patient is having stroke. Congestive heart failure, this is a very catchy because in these patients what they'll have in moderate exertion, at least few steps they'll develop shortness of breath. These patients are very fitter to do exercise. You have to be very careful because these patients may land up into your ER with cardiac failure which is being precipitated with your exercises. You have to be very careful in these patients. Lastly, peripheral arterial disease. The thing is like yesterday my teachers also told me, you shouldn't see from head to toe, you have to see from toe to head. That is very important. If you don't see the toe, then definitely you are missing many things. That is very important. Lower extremity examination should be done. If a patient is having peripheral arterial disease and if foot sensations are not there, these patients are vulnerable to develop pressure sores, pressure ulcers as well as foot deformities can also be there. So you have to take care of all those things.
Riaz, I think this slide, this slide is conclusive, I think.
Sorry, sir?
This slide is quite good.
Yes, sir.
So we will end here because.
That's what I said. In interest of time, I'll be not going to another slides. If any questions are there, it will be like dealt with.
Yeah, so we'll take 2 or 3 minutes because for any questions if you have on the, because lots of things are to discuss, exercise in pregnancy, the timing of exercise, and many other things. So any.
Preferably morning. People are working in the morning like me.
Akash, will you tell why in the morning or
Why
evening?
morning?
Or Dr. Kulfest?
Yeah.
Look, clear-cut, the research has now shown that the afternoon exercise is more efficacious than the morning exercise. But isko bhul jaiye, you just remember the time your patient gets, which is comfortable for him, but must tell them to do that. But even in our Vedic science, definitely the morning exercise has been told much better. But now due to chronomedicine, that Narsingh Verma is here, the afternoon exercise tunes with the chronomedicine. So lots of papers, even the recent papers are telling, yeah, you can do that there. So this is again the intensity and duration. Intensity is more important than the duration, remember. Duration is not more important, remember. The intensity of exercise is more important than the duration for the glycemic control.
In fact, in aerobic exercise, HIIT raises your insulin levels for a more prolonged period than a simple exercise. So that is why HIIT is a much more preferable, but you need cardiovascular fitness.
So Dr. Amal Bhattacharya, do you have a proper evidence today to recommend yoga in diabetes?
There are.
You can tell. Yeah.
See, nowadays, any chronic disease, including arthritis, cerebrovascular accident, even actually it acts through the hypothalamic axis, pituitary and peripheral. So what are the neurotransmitters which are inhibited like GABA? They are enhanced, and all stimulatory neurotransmitters are suppressed. And they are proved by the evidence-based data.
That's fine. So, Dr. Riaz, many patients of yours might be having with osteoarthritis. What do you do, or what do you tell to those patients? How to go?
See, sir, it depends on the grade of osteoarthritis. If suppose the patient is having advanced osteoarthritis, then definitely they'll be not able to do exercises which involve predominantly the lower limb. I ask them to do upper limb exercises and foot exercises that would help the patient. That's point number one. Grade 1, grade 2, there's no barrier. You can give it, under the precautionary care, you can go ahead with the exercises. There's no hard and fast rule that the patients cannot do it. But the catch is, you can do only mild to moderate. These patients are not fit for doing severe exercises or hard exercises, whatever we call it. Moderate, mild cardiotone exercise or physical activity in the form of walking as well as aerobic exercise, what sir have said, definitely will help the patient. Lastly, if the patient is able to swim, I'll say that would be the best exercise if they can do it, because that involves all the part of the body, and that would be great. At least twice in a week, I can tell it. If they can't do, at least alternate day.
Yeah, last question from Dr. Akash. Why we are not recommending our diabetic patients for running, because running is also very good. So what's your advice about the running and walking?
Actually, we do advise our patients to running, but we must rule out a underlying IHD, because if that is there, then this sudden burst of exercises can be harmful. So if the patient is contemplating running, then they should undergo a proper cardiovascular fitness from a qualified physician or cardiologist, and only after certifying that should the patient run. I am in the running half marathons, and in our marathon group, every year there is 1 or 2 deaths because of sudden MI, because these are people who think they are invincible, they are eating and drinking a lot, and only aerobic exercise does not take away the risk of IHD and sudden acute coronary events.
Thank you. So I will now conclude this session by asking last question to Kulshrestha. Sir, in pregnancy, you told about the aerobic exercise. What do you recommend in the pregnancy? Pregnancy with diabetes.
Pregnancy with diabetes, the only exercise which is possible is walking, and sometime stationary cycle.
Yeah,
Early
cycling.
pregnancy.
Yeah, exactly.
That can be done.
That can be done. Meena, any?
What is the answer? Can people go up and down steps, diabetic?
Why not? In pregnancy, the exercise,
Yeah,
aerobic
pregnancy.
exercise, even some resistance form of exercise is recommended. There is no contraindication at all as such. Yoga. Yeah, yoga in the under guidance, yeah, that's fine. But this is a separate topic. In the same way, the type 1 and exercise is a different topic. I have not touched that. So due to paucity of time, I will end here that before ending, it will be better if you all become a stand-up again and do some stretching like that. So that will be much better. So that is the final recommendations. Thank you very much. Yeah. Moving like that. So, okay. Thank you very much. All our panelists have done wonderful job. Thank you. हाँ? मैं दिखा दूँ मैं कर सकता हूँ आप करेंगे
So you can always see him doing the Surya Namaskar. Please go ahead. I am doing an announcement, don't worry about it. So we have the next session, which is ISH, Indian Society of Hypertension session. And for that we have chairpersons, Dr. Smita Bhatt, Dr. Anil Kusist, Dr. Bhagirath Solanki. So after doing Surya Namaskar, you're requested to come on stage for chairing the event. And the speaker, a round of applause for Dr. N.K. Singh. He will be available during lunchtime as well. So pre-lunch, please do that. For this ISS symposium, we have speakers, Dr. Narsingh Verma, sir. Dr. Verma, good. And Dr. S.S. Daria, Dr. Rajni Saxena, Dr. Sajid Ansari, and myself. So we are going to start without wasting time. So over to you, Chairperson, sir. Let me introduce Dr. Narsingh Verma, who is known to everyone. He is presently the principal and the dean, Hinds Institute of Medical Science, Ataria, Sitapur. He is the ex-professor and head, Department of Physiology, office-sitting head, Department of Family Medicine, former head, Transfusion Medicine, and former medical superintendent GM and associate hospital KGMU, Lucknow. He has lots and lots of original publication up to the tune of 209. Past President of Asia Pacific Society of Hypertension, President Indian Society of Medical Food and Nutrition. He is the immediate past President International College of Nutrition, Association of Physiologists of India, UP Diabetes Association, and Vice President Asian Heart Society. He is the Secretary of Indian Society of Chronomedicine, Secretary, American College of Physicians, Indian Chapter, and Treasurer, RSSDI UP Chapter. He is the Director of Southeast Asia World Hypertension League, and he is going to give his insight into the BP monitoring, the grand study, which probably all of us have taken part into that. Please, sir. I've done your job.
Sir, but before, I just want to say it's such an honor to chair a session like this. Sir has been generous enough to give many of us the opportunity to participate in the study. Very grateful for that, sir. So over to you for the insights into the study.
Thank you, chairpersons. Thank you, Dr. Patni, for inviting in this DRW conference. Again, I have been part of this conference since, I think, very beginning, not first, but very beginning. So today, my job is to talk about insights, newer insights in BP monitoring. And everybody will agree to this statement given by Norman Kaplan that the measurement of blood pressure is the clinical procedure of greatest importance, but has been performed in the slopiest manner. And Professor Kamalakar Tripathi sir will also agree that this very important clinical method has been ignored for a very long time. And we know today we have lot of methods to measure blood pressure, and that can be palpatory, auscultatory, oscillatory, office, ABPM, home monitoring, and the automatic office BP measurement. And here the problem at present India is facing that in most of the Indian schools of medicine, we are teaching our students only palpatory, auscultatory, and they are going to use the oscillatory one. Oscillatory is not being discussed in the medical schools, and we, especially our branch of physiology, is responsible for that because they are not teaching the auscultatory one. And here lies the difference in auscultatory, palpatory, and oscillatory. So in oscillatory, basically these oscillations are picked up, and because of that, it becomes the most important method today in clinical tool to measure blood pressure. And when we talk about which blood pressure you are talking about, then the values also become important. In office BP, systolic blood pressure is more than 140 and more than 90, then we say it is hypertension. But in ambulatory blood pressure, the daytime more than 135, nighttime even more than 120 is hypertension. So the value is not important. It is also important that which type of method you are using. The nighttime BP during a sleep, it is more than 120 or 70. Diastolic, it is hypertension. So in 24-hour average, it is more than 130 and 80, and home BP 135 and 85. So these are the values for different type of measurement of blood pressure. And prerequisites are very, very important, which are often missed. These prerequisites are very important to measure blood pressure, because most of the time in my country, blood pressure is measured only at the time of emergency by the various people, not by the doctors. So these things which are written here, they have been repeated several times, but never practiced. These things are very, very important. The 5-minute rest and avoidance of alcohol, tobacco, etc., bladder bubble, comfortable, and the tight clothings, room temperature, no talking, physical activity, emotional drive, and any acute physical morbidity will definitely change the blood pressure, which cannot be taken as a monitoring for the hypertension. And these are the various conditions where the blood pressure will rise. So the patient is having all these conditions, then this will not be hypertension. This will only be called as a labile one, or it can be called as the episodic hypertension, but this does not warrant as hypertension. These conditions are very, very important. We must rule out them, or we must take in account to them when we are measuring blood pressure. These again, the important what we are measuring blood pressure. At that time, activity is very important. The cuff is very small, then the 10 to 40 millimeter of mercury blood pressure rise can be there. And if the cuff or clothing, which is very, very common during winter days, and that again will have the measurement 10 to 40 millimeter of mercury decrease or increase depending upon the position of the cuff, and back feet unsupported will have the difference 5 to 15 millimeter of mercury. Legs crossed which is very, very common condition. 5 to 8 millimeter of mercury difference can be there. Non-resting 3 to 5 minutes, which is very common in busy OPD setting. 10 to 20 millimeter of mercury, and patient talking, doctor is also talking. Both are talking, and 10 to 15 millimeter of mercury increase can be there. If the patient is having any pain, which is very, very common, then the 10 to 30 millimeter of mercury rise in blood pressure can be there. So we have to take in account these conditions while mentioning the pressure in our most of our patients. Okay, sorry. So, what I am talking will definitely have the few questions at the end to the youngsters, and if they answer, that is very, very nice. So, please, these conditions are very important when we are measuring blood pressure, and the correct size of cuff is again very, very important in the children's, small adults and adult size, large adult size and extra large adult size cuff are there, and these cuffs had to be there, and most of the time these cuffs are not present in our clinic. So the best thing can be that we can advise the patient that your blood pressure will require a special cuff, and you have to purchase it, and you come with that cuff every time, because the clinician or physician cannot have these different type of cuffs in his clinic. And nowadays a lot of disposable cuffs are also available, and they are being used in a lot of institutes like SGPGI. They have disposable cuffs which are being used. These things are very, very common, and they have been talked several times that this is the positioning, how the blood pressure should be measured. Very important. Again, talking too much, not being practiced in daily practice, maybe because of several reasons. Since 2010, the AHA and other bodies are trying to have these things in the measurement of blood pressure, but they have never been practiced. All these conditions which are very important, the using a cuff size and the middle of the cuff at the heart level and lower edge of the cuff 3 centimeter above the elbow crease. All these things are very, very important. Legs uncrossed, feet flat on the floor, not hanging and not cross one. These things are very, very important. So how to measure blood pressure? Again, sitting blood pressure is more routinely done, but the ideally measure standing blood pressure also in several conditions, like in elderly patients, in patients who have diabetes and other conditions where we are suspecting any autonomic dysfunction. Report and document difference may need further investigation. When the readings are different, then we may require more readings as well. Support arm at heart level, again important. Palpate the pulse, tight clothings, choose the correct monitor, because monitor, again in India we have several type of monitors, but according to the governing bodies, only 2 monitors at present in India we have. Those have been validated, well validated monitors. And choosing the correct size cuff, and patient must keep still and not talking during the readings. Again, very important. I showed that how it is going to influence the reading. Benefits of automated over the manual one is still, most of our physicians feel that the manual is better, and they still feel that automated machines are not correct, and they overestimate the blood pressure. But that is not correct. Most of the research has shown that they are more sensitive and they measure blood pressure more accurately, correctly. It is the condition which is important. That is why the difference is there in different readings. It is not the fault of the monitor. It has shown that the automated one are better than the manual one, and they have been recommended by so many bodies, and awake ambulatory BP and home BP measurements have been found to have the similar type of the diagnosing hypertension capacity. An oscillometric device automatically obtain an average 3 or more readings, which is again very, very important, and that facility cannot exist in the manual one. In manual one, every reading will have its own differences. Validated automated devices are readily available, and we have very good devices at present, so we can say that automated is the new thing, and we have to adopt 100%. And at present, most of the physicians are agreeing, but still they have doubts about the automated one. The clinical indications for home monitoring are there, and they have been verified by most of the guidelines, and they are the assessing the presence of white coat hypertension or mask hypertension. These two conditions, and monitoring of antihypertensive medication, where our medication is adequate or we need to accelerate it, this requires the home monitoring. And the advantage are plenty in home monitoring over the conventional BP measurement. And I have mentioned here the cost effective and the annulling the white coat effect and improving the patient's compliance with treatment, because patient when measure it, it has more compliance and he will agree that we require treatment. Possibility of digital storage of readings is also there, and most of the patient come with a monitor with having a lot of digital storage of the data, and we can see that. The home blood pressure diary is again very important. This type of diary is available online. You can use it and you can distribute to your patient, and they can come to you with this type of diary. That shows specifically that we require only 2 readings in the morning and 2 readings in the evening. In the meantime, different times we don't require any reading. That also helps to educate our patient that every hourly, half-hourly blood pressure measurement has no value. Only 2 readings in the morning and 2 in the night are enough. And the comparison of ambulatory and home monitoring has also been done by the various agencies. This ESH-ESC guideline in 2018 has very well compared the two, has found that most of the advantages of ABPM are also with the home monitoring, and home monitoring can be preferred because of the cumbersome process of the ambulatory one, which still we require ambulatory in certain conditions. I cannot say that it is not required. Validation, about validation, we have now good source to find out the validated equipments. For that, these websites I have mentioned, they are there. You can find out the list of validated equipments where you can find your choice of equipment in the Indian market. In India, the current status of home monitoring has been done all the Asian countries. This research was also done in India. India was also part of that. And we found that the published local hypertensive guidelines were present in almost every country, but published local home monitoring guidelines were missing. And Indian Society of Hypertension is very soon going to work on this, and we will also have our own home monitoring guidelines, and I will invite to our friends to have a particular committee for that. And in the next year APCH, by that we will develop the home monitoring guidelines as well. We are working on that. Facts regarding home monitoring in Asian countries are that low awareness in India, low apprehension of the home monitoring in general physicians, and the home monitoring guidelines are missing. These are the facts which have highlighted in the studies which I have done. This publication was done by the Indian Society of Hypertension as well. The part of that, insights of the home blood pressure monitoring in Asia, expert perspective from the 10 countries, the data were collected. These data were collected during the COVID time. So that is another important thing, because at that time, data collection was very difficult, and for India, only we collected 7,000 data. Finger cuff monitors are available, but still I will say they are not validated. So we cannot rely for the finger cuff monitors. They can be used for monitoring for personal use, but they cannot be used for diagnosing hypertension or for the decision of increasing or decreasing drugs. Wrist monitors, again, the various companies have come very good wrist monitors, and some of them are validated one, but still we require more data to say that wrist monitors are good. Because in wrist monitor, the one problem is that the wrist movement or the positioning of wrist and the distance or the level from the heart level again makes a problem, and different type of readings you can obtain. At present, I am doing one study that I am comparing most of my patients of the monitor use and the wrist monitor, and comparing these data. Very soon I will publish this, and then will be available for the use of the physicians. The smartphone technology, again very, very common. but not reliable. Still, any recommendations are not for that, and cannot say they are validated one, but they can be used for personal use. The wearable sensors and cuffless BP monitors, they are coming in the market. We have plenty of them, but still, again, the validation is a problem, and validated one are not present. This is the wearable ambulatory blood pressure monitor, no tube, no wire, only monitor. But again, validation is a problem, not recommended by most of the bodies. Mask hypertension diagnosis can only be made either by ABPM or home monitoring, and it was firstly described by the Pickering and colleagues in 2002. And initially, it was talked about mean out-of-office BP in the hypertensive range, with BP not in the hypertensive range when measured in the office. Later on, it was more complicated, and we were also considering the night blood pressure. And during the night blood pressure it was talked about. I will take 2-3 minutes more. And then the mask hypertension, we found in our study, in grand study, I will describe that. Before that, the screening and diagnosis of hypertension, we have this particular guideline, which is again very, very important, and we have taken into account this guideline to Indian Society of Hypertension guidelines as well. India grand study, I think everybody in the Indian Society of Hypertension knows it, and most of you have been the part of this study. And in this study, we have found certain things which I will talk very quickly. And we've noticed that the real BP control rate, it was the combination of clinic, it should be clinic BP and out of office BP. Most of the data in India Heart Study and other studies been only the clinic BP. Out of office BP has not been considered. So this grand study is the only study where the out of office BP were considered, and because of that, this study was designed. And finally, we found that clinic and home blood pressure measurement, and you see here in this particular slide, the clinic BP mean and the home BP mean is almost same when we talk about overall, but the difference is that in the white coat and mask hypertension, they differ. So for diagnosis of white coat and mask hypertension, we require the out of office BP measurement as well, because you see in this most of the other data are almost same, but when we talk about white coat and mask hypertension, they differ. That is why the study has pointed out this. Distribution of blood pressure and control status overall, you see here the mask hypertension was very high in Indian population, 15%, and the control, which was thought that the control is bad, but the grand study has found that control is not so bad. Whatever you have reported, the investigators were from India only, from all corners of the India, and they have reported good control. Almost the control was in the range of 66%. So it is not that bad. To summarize the grand study, because more and more data are being accumulated, and in the September, when we have Indian Society of Hypertension conference at Jaipur, the grand study will be presented there with almost all data available. So to summarize the data, whatever we had in the grand study, the difference in BP control across India and the prominent hypertension category, overall mask hypertension was 15%, which is higher prevalence than white coat hypertension, 5%. And across regions, the prevalence of the 4 hypertension categories varied. However, mask hypertension consistently had a higher prevalence than white coat hypertension, all corners of the country. Then the summary 2, last 2 slides, the prevalence of home monitoring and the HBP device ownership. Overall, the prevalence of home BP measurement is higher than the ownership of home BP device. And Jharkhand region has maximum device in their home. That came out of this study. So this study is the first multi-center study among hypertensive patients in India. We conclude that overall mask hypertension was 3 times higher than the white coat hypertension. 50% of the hypertension patients practice measuring their blood pressure at home, and the results show the importance of home monitoring in hypertension management and control. A stronger recommendation is needed to implement this 50 to 100%. we acknowledge the participant of the home monitoring, this grand study research group, and you see we include a lot of our Indian, every corner of India was represented in this grand study. So with this, I will like to conclude that the we would like to conclude that the measurement of BP is very essential part of clinical examination. Today we have so many options to measure blood pressure. Pitfalls in measurements are plenty. We have to address them, and guidelines for measurement should be followed. ABPM and home monitoring are very useful. Newer gadgets need more validation, but they are the future. Thank you. Thank you very much.